Good afternoon, friends. I am Dr. Pankaj Maheshwari, Senior Consultant and Chief of Urology at Fortis Hospital, Milund. I welcome you to this presentation on exit strategies after PCNL on edmed.com. Friends, PCNL is a standard treatment and often a first choice treatment for large and complex renal calculi and calculi in upper ureter. Although during PCNL you would remove the stone, making a small tract through the back in the kidney. Once the stone is removed, the last step of PCNL is to do something for the tract. This is what we mean by exit strategy. What are the options? The standard treatment option has been a externalized nephrostomy tube or a nephroureteral stent. So a tube is placed through the implant sheath with one end in the renal pelvis and the other end attached to a urine bag externally. You could add or keep alone an internal ureteral stent. This would help in proper drainage of the kidney, help in small clots to drain down in the bladder. Recently, a new trend has come up where a no tube is kept at all, which is called as a tubeless PCNL. Now, externalized nephrostomy tube has been the conventional practice since the time PCNL started more than nearly 30 years back. Some form of tube has been kept in the tract. This could be either a Foley balloon catheter or a Malico catheter where the flower has been cut in, or a nephroureteral stent where there is a nephrostomy tube and the internal end tapers down in the upper ureter as a double J stent. Nephrostomy tubes are extremely helpful when you land in difficulty during PCNL, may it be related to intraoperative bleeding or if accidentally you cause a large perforation in the pelvic ileal system. Why was nephrostomy tube put to begin with? One of the most important reasons for putting in the nephrostomy tube was to have a good drainage of the urinary tract. During PCNL, there may be some stone fragments which remain in the system. There could be some bleeding and some clot formation. You want the urine to drain well. You want the small fragments to drain out. You want the small clots not to block the pelvic ileal system. The nephrostomy tube serves as a good access for a second procedure if needed after the primary procedure, and this would be needed if you had to curtail the procedure midway because of some surgical problem or because if there has been a residual calculus after the procedure. Initially, the nephrostomy tube was thought to play a role for tamponade of the tract, and this tube was proposed to help in reducing the bleeding. This tamponade of the tract has been debated in last decade or so. Now, what size of the nephrostomy tube to put? We, as a group at RG Stone Clinic Khar, were the first group to do a study whether a standard large bore nephrostomy tube is needed or it could be replaced by a pigtail catheter. The initial standard practice was to place a 30 French nephrostomy tube or a nephrostomy tube which was 2 French smaller than the implant tract. We compared our experience with a large bore catheter with a pigtail catheter. After us, there have been many studies which have given results similar to our results. And the results were that if you use a smaller nephrostomy tube, you do not increase the risk of bleeding. Rather, the patient has a smoother postoperative course, the pain is much less. The tract tends to collapse over the nephrostomy tube and hence there is very less leakage once you remove the nephrostomy tube, and just placement of a small bore tube does not increase the risk of bleeding. So the initial hypothesis probably that the tube was needed as a tamponade no longer held true. Rather, it was shown that patients who had large bore nephrostomy tube, there was a higher risk of bleeding when the tube was removed because the large tube did not let the tract to collapse. Further extension of this was whether the tube could be completely avoided. This was initially proposed way back by Wickham in 1984, but his proposition went into oblivion immediately because Winfield reported disastrous outcomes of PCNL without a nephrostomy tube. If bleeding happened, then there was no control over the kidney without a nephrostomy tube. In 1997, Bellman revived this and he placed, instead of a nephrostomy tube, just a DJ stent for a week or two. When we see tubeless, we only mean PCNL without a nephrostomy tube. In essence, some tube is placed, that is, a ureteral stent is always placed for a short period. Why should we do a tubeless PCNL? The tubeless PCNL, there will be absolutely less pain and hence less analgesic use. Patient does not have to move around with the external drainage bag, and this drainage bag adds morbidity to the patient. Because the tract collapses immediately after you remove the nephrostomy, because without a nephrostomy tube, after you remove the implant sheath, the hospital stay is reduced, because usually after a large bore nephrostomy tube, patient has prolonged leakage and hence the hospital stay increases. With increasing analgesics, increasing stay, the healthcare cost definitely goes down. When would we consider a tubeless PCNL? A tubeless PCNL may be considered if you do not need the external drainage. External drainage will be needed in patients who have pyonephrosis. We definitely want a draining system when there is infection. Obviously, when there is infection, the procedure will be curtailed. When there is significant bleeding, the nephrostomy tube is important. And if we have injured the collecting system, surely the nephrostomy tube is needed. I would consider tubeless when I feel that secondary procedure probably is not needed. Tubeless PCNL obviously cannot be done when there is bleeding, perforation, or when I'm sure I would need a check nephroscopy. How does tubeless compare with large bore nephrostomy tube? Now, this difference is very, very obvious, and a lot of studies have demonstrated that tubeless PCNL has a major advantage over large bore nephrostomy tube. Less painkillers, less hospital stay, early return to activity, and overall a less cost. How does tubeless compare to a small bore nephrostomy tube? Now, the difference is not as obvious as would be between a tubeless and a large bore tube, but surely there may be a small decrease in narcotic use, small reduction in hospital stay, and probably an early return to normal activity. Can we replace a nephrostomy tube by a DJ stent? DJ stent has some obvious disadvantages. One, because there is a stent and no nephrostomy tube, you have no control on the tract and the tract gets lost. So in any situation when you want to re-explore the tract, this would become difficult. And whenever you place a stent, an additional procedure is needed when you need to remove the stent. So totally tubeless would be done in patients who have low volume stones. The tract is a single tract, a traumatic tract. The procedure went extremely smooth without any bleeding, perforation, and there have been no residual obstructions used. To make tubeless safe or to reduce the risk of bleeding during tubeless, some adjuncts to tubeless have been tried. These adjuncts were either you could cauterize the tract with a monopolar cautery, though this would reduce bleeding through the tract, but then you are leaving behind cauterized tissue or a necrotic tissue in the tract, the risk of infection and the risk of secondary bleeding could be higher. OKK tried cryo treatment of the tract. Probably both these are a overkill during PCNL. The further things that could be done was these tubes, these tracts could be filled with some insertions or hemostatic agent. And a lot of hemostatic agents like oxidized cellulose, gelatin sponge, gelatin granules, thrombin, and fibrin glue have been tried. The utility of this remains uncertain, and surely more studies need to be done. There would be some special situations which will help us or make us change our treatment plan. One of the common situation is making a supracostal access. Supracostal access is a brilliant access when you want to treat a staghorn stone or a stone with multiple components in upper calyx, renal pelvis, lower calyx, and upper ureter. One tract which will give access to all four sites would be a supracostal tract. Once you have finished your PCNL through a supracostal tract, look at the CP angle at the end of procedure. If you see a clear CP angle at the end of procedure with the patient breathing during under anesthesia, you can rest assured that your tract has not gone through the CP angle. Nephrostomy tube should always be kept in supracostal access. It is not safe, though there are reports of PCNL without supracostal access, without nephrostomy tube. Probably it is not safe. At the end of procedure, you could give a nerve block. This will reduce the pain of a supracostal access. Now, suppose your supracostal axis, your CP angle is obscured, and you have diagnosed that there has been a pleural violation. If there is a pleural violation and if you have diagnosed it on table, then you would either diagnose it by reduced air entry or by obscured CP angle. So immediately get a chest radiography or ultrasonography done. Use your initial puncture needle and make a pleural tap. Many a times this is the clear fluid that has intravasated in the pleural cavity during your PCNL. And if this is the clear fluid, there is no continuous collection of fluid, so just aspiration would all that be needed. And you can use your initial puncture needle of PCNL, put it in the mid axillary line, maybe around in the fourth intercostal space, and aspirate out the fluid. If the fluid collection is large, or if there is blood in the pleural space, then a nephrostomy chest tube could be placed. Suppose on table you couldn't find any pleural violation, but once the patient is in ward or recovery, that is the time you realize that there is collection in the fluid. Now, if there is a late presentation, the decision of treatment would be based on whether you have placed a stent or not. If the stent is there, then many times there could be reflux through the stent because of bladder spasms, and this is causing collection in the chest. In this situation, place a Foley catheter and put the patient on anticholinergics so that the bladder spasms stop. You may decide to place a chest drain based on how much collection is there. If there is no stent placed during PCNL, then this collection could be related to a small stone or a clot which is blocking the pelvic system. In this situation, a stent would need to be placed. With the stent, you would obviously keep a Foley catheter, give the patient bladder laxants, and put chest tube based on how the situations are. If you have treated a complex stone and if there are multiple tracts needed, then always try to keep a nephrostomy tube at least in one of the tracts. This could be either the major tract or in the difficult tract. So at least one tract. You do not need nephrostomy tubes in all tracts. At least one tract should have a nephrostomy tube. There could be situations when you have had to make an emergency exit during PCNL. This would happen if patient has had significant bleeding. More often than not, this bleeding happens because of the overshooting of your dilators, and the bleeding happens from the opposite wall. Try to identify this site of bleeding, go beyond this site of bleeding, place a large bore nephrostomy tube and clamp this tube, give a compression dressing. If at the time of trying to identify the bleeding, if you luckily find a single arterial pumper, you could use electrocautery and coagulate this bleeding, but more often than not, a single bleeder would not be found. So a large bore nephrostomy tube which is clamped and compression dressing is all is needed. Once the tube is clamped, a clot forms and the clot itself tamponades the further bleeding. If the bleeding is from the renal puncture or tract side, then again a large bore nephrostomy tube. A tamponade catheter may be used. Standard is a case nephrostomy balloon catheter. This more often than not is not available in our situations. What we have started doing is using a Foley balloon instead of a case nephrostomy balloon. I'll show you how that balloon is to be placed. As I've already said, very rarely if a single point bleed is found, then electrocoagulation could be done. Now, if I have to place a Foley balloon as a tamponade, and when the bleeding is through the tract, I withdraw the implant sheet till the edge of the pelvic system, place a end hole Foley balloon. So the tip of the Foley balloon beyond the balloon should be cut. Withdraw the implant sheet just outside the pelvic system, place a Foley balloon, place a catheter and inflate the balloon to 10 cc. Slightly withdraw the catheter so that a mild traction is placed on the catheter. This will immediately stop the bleeding. Now reduce the balloon by 5 cc every day. Wait till you have kept the Foley balloon without a balloon for at least 24 hours and then remove the balloon. This would take care of many major bleeders. If there has been a perforation of the pelvic system, the problems with this would be the calculi fragments would extrude through the PCS and they would remain as persistent radiopaque density in future imaging. You need to inform the patient that such fragments are there so that they don't get confused. These could be a source of infection. This would be the problems later on. The immediate problems would be the system would collapse and make the procedure difficult. There could be a lot of fluid that gets intravasated during the procedure and this could land the patient into fluid overload. So if there is a perforation of the system and if the perforation is small, no treatment other than nephrostomy tube is needed. If the perforation is large, stage the procedure, place a nephrostomy tube in a normal pelvical system away from the site of perforation. Wait for 24 to 48 hours, and after 48 hours through the same tract you could complete your procedure. A degestant would always be placed at the end of procedure. Friends, before I conclude, I would want to say that if it's a clean PCNL, a traumatic access, no bleeding, perforation, or infection, and I have completely cleared the stone, I may consider tubeless PCNL. If there is, I would place a digestate if there has been a large stone which needed extensive fragmentation, because there is always a risk some fragments may have gone down. If there are residual fragments, if there is solitary kidney, or if there are minor perforations. I would place a large bore nephrostomy tube in a difficult PCNL in at least one tract if there is infection, or if I am sure that I would need a second tract. Finally, small bore nephrostomy tube will be kept in a clean patient where I am not sure of complete clearance and I am not completely convinced of a tubeless PCNL. Thank you very much. I invite you to visit our site edmedonline.com for other presentations on various aspects of medicine. Thank you. Best wishes.